My name is Caleb Dowell. I am a nurse and a student at the College of Nursing at St. Pete College. This is my presentation on varices and variceal hemorrhage for my pathophysiology class. First, we will be taking a look at some definitions and the objectives of this presentation. Our first definition is that varices are a complication of portal vein hypertension which causes dilation of veins located in a person's distal esophagus and proximal stomach. Variceal hemorrhage is where these dilated varices rupture, resulting in life-threatening blood loss. In this presentation, we will be exploring variceal hemorrhage and the following objectives: its impact on the U.S. population, its etiology and risk factors, its pathophysiology, its clinical manifestations and complications, its treatment, and its nursing evidence-based practice related to it. And Figure 1 shows the locations of these veins and varices in the esophagus and in the stomach. Variceal hemorrhages and its impact on the U.S. population. Gastroesophageal varices occur in about 50% of patients with liver cirrhosis. Once a varice ruptures, there's about a 20% chance of a 6-week mortality. Between 2011 and 2018, there were 322,761 patients admitted to hospitals for esophageal varices in the United States. Out of those patients, 66% were white, 20% were Hispanic, 8% were black, 70% were male, and about 30% were female. And over 50% of this population was between the ages of 51 and 65 years old. There are between 6,000 and 7,000 deaths from variceal bleeds per year in the United States. The most recent cost analysis of esophageal varice treatment was performed in 2011. At this time, they determined that the annual treatment cost was about $690 million. Now let's look at the etiology and risk factors. Varices are caused by liver cirrhosis. Cirrhosis is defined by fibrosis of the liver from chronic injury. Causes and risk factors of cirrhosis include: the most common are alcoholic liver disease, hepatitis C virus, non-alcoholic steatohepatitis, which is caused by a fatty liver, and then less common causes are hepatitis B virus, drug-induced liver cirrhosis, chronic right-sided heart failure, which causes portal vein hypertension and therefore liver cirrhosis, autoimmune hepatitis, Wilson's disease, which causes copper buildup in the liver, which causes cirrhosis, and Budd-Chiari syndrome, causing narrowing of the vessels in the liver, which also causes cirrhosis. Now let's look at the pathophysiology. It starts with hepatic stellate cells, or HSCs, which make up part of the wall lining of our liver. When the HSCs are exposed to inflammatory cytokines from chronic injury, they transform into myofibrinoblast and deposit collagen, which leads to fibrosis. Over time, the liver becomes more fibrotic, causing an increase in intrahepatic resistance, making it more challenging for blood to travel through the liver. This results in portal vein hypertension. Portal vein hypertension results in venous remodeling, causing esophageal and stomach veins to dilate, turning into varices. If left untreated, the high pressure from the portal vein hypertension will continue to stretch the varices until they rupture and cause life-threatening bleeding. The increase in portal vein pressure can also cause damage to the spleen, which results in splenomegaly, and splenomegaly causes thrombocytopenia, which can increase the risk of bleeding. In Figure 2, it depicts the portal vein hypertension enlarging and remodeling the vessels, causing the varices and the splenomegaly. Clinical manifestations and complications. Signs and symptoms of varices usually don't occur until they start to bleed, which occurs in the latent stages of liver cirrhosis. Signs and symptoms related to varices include nausea, vomiting bright red blood or dark coffee ground-like substance, having black tarry stools, dizziness, fatigue, tachycardia, tachypnea, and hypotension. Lab findings often reflect an increase in ALT, AST, bilirubin, PT, creatinine, BUN, and ammonia, and a decrease in hemoglobin platelets and fibrinogen. Diagnosis is determined by an EGD, and severity is determined by the size of the varices, which is seen on EGD. The higher the grade, the higher the chance of bleeding, and the higher mortality rate. Grade 1 varices extend just above the mucus level. Grade 2 varices project about 1/3 of the diameter and cannot be compressed by air insufflation. And grade 3 varices project up to 50% of the diameter and are in contact with each other. Complications that occur alongside variceal hemorrhage include splenomegaly and thrombocytopenia. This is due to portal vein hypertension causing splenomegaly, lowering the patient's platelet counts, causing an increased risk of bleeding. Coagulopathies, and even DISC, and this is due to the liver being responsible for creating multiple clotting factors and anticoagulant proteins. And because of this, when you reach end-stage liver cirrhosis, you are more prone to bleed and develop blood clots when you're not supposed to. This can cause DIC. Encephalopathy, because the liver isn't filtering out toxins like it normally should from the blood, patients can become confused and lethargic. Patients can develop liver shock due to the increased amount of nitric oxide building up in the blood, causing hypotension, or causing vasodilation and hypotension. And it can also cause hepatorenal dysfunction. The vasodilation and cirrhosis leads to hypotension and the action of the renin system, which causes sodium and water retention and renal vascular constriction. All of this leads to decreased renal perfusion and hepatorenal dysfunction. Treatment for variceal hemorrhage starts with stabilizing the patient and getting them ready for an EGD. Standard of care is to perform the EGD within 12 hours and not rushing to do the EGD because this can actually cause an increase in mortality. Because of this, the patients will be transferred to the ICU for close observation and treatment. Some pharmacologic agents that are used are vasopressors and octreotide. Vasopressors act by increasing the blood pressure in hypotension, by agonizing the alpha and beta receptors, causing vasoconstriction and increased inotropy and chronotropy. Octreotide, on the other hand, is a splenic vasoconstrictor, which helps to clamp down the bleeding vessels. And sometimes this alone can actually stop the bleeding vessels without any other intervention. Blood products are also given, such as RBCs and FFP, to replenish what the patient is losing, but also to replenish clotting factors to help the patient stop bleeding. It's important not to over-resuscitate these patients, because making their blood pressure too high can actually make bleeding worse or cause rebleeding. Antibiotics are also been shown to decrease mortality in multiple randomized clinical trials and are started as soon as the patient comes into the door. Other procedural interventions are intubation. This usually happens during resuscitation in preparation for the EGD and also to protect the airway. And the primary treatment for bleeding varices is an EGD with banding. This is a diagnostic tool and a therapeutic tool performed by the GI doctor, where they guide the scope down the esophagus and into the stomach, which has a camera and a light at the end, and so they're able to visualize the varices. Once visualized, they're able to suck it up and place a rubber band over it to stop the bleeding and prevent blood flow from going through the vessel. If this is unsuccessful, or if the bands pop off, a balloon tamponade or Blakemore tube would need to be placed. This is seen in Figure 3. This is a device that's guided into the stomach that has two balloons, one that inflates in the stomach and the other one that inflates along the length of the tube, which applies pressure on the wall of the esophagus and stops the bleeding. After bleeding is stopped, the patient can receive a TIPS procedure, which is basically a bypass of the portal vein to the hepatic vein. This bypasses and decompresses the portal vein, helping the portal vein hypertension and reducing pressures of the varices. Nursing evidence-based practice. In 2024, an Egyptian nursing journal published a study that showed that when nurses are educated appropriately and on the topics and on the nursing interventions, it allows for EGDs to be done quicker and patients may have better chances of recovery. In the study, they took 30 nurses and 60 patients and did interviews for nurses before and after education on esophageal varices hemorrhaging. Then they compared patient care that was performed before the education and after, and it showed that expanding education on the topic of variceal hemorrhage and the need for nursing interventions improved nursing practice. Nursing interventions and knowledge can greatly improve patient care. Some of these interventions that they listed are being educated about the underlying cause and effect, understanding the signs and symptoms, risk factors, and medical management, adequate infection control, including hand hygiene and use of PPE, thorough assessments, including airway, breathing, and circulation, acute management, including adequate suction, monitoring vitals, multiple large bore IVs, staying on top of labs, giving medications, preparing for the EGD and blood transfusions as needed, and also preventing secondary bleeding, not over-resuscitating, communicating assessment findings with the doctors. This data was shown to encourage hospitals to provide nurses with adequate training for the disease processes that they will encounter. The remaining slides provide the sources used in this video.